All right, I guess we can get started. It's 1 minute
Okay.
after. I just wanted to welcome everyone here for our, I guess it's our fifth session with Dr. Westley on stewardship and intra-abdominal infections. So without further ado, I'm just going to hand it over to Dr. Westley.
Okay, great. We are on module 5. The series is going quickly, and so today we'll talk about intra-abdominal infections. These are a little more complex and um, annoying to treat compared to more formulaic stuff we did the first few modules, but unfortunately these are pretty common in the hospitals we work in. So the objectives today will just be to review different categories of these infections, which help us pick antimicrobials. Most of these are community acquired, such as diverticulitis or appendicitis, and then we just characterize those by either mild to moderate or severe patients with risk factors similar to severe. So we'll go over all that. There are also acute biliary tract infections such as cholecystitis or cholangitis, and then there are nosocomial intra-abdominal infections, usually after surgeries of some sort. These are more common than we'd like them to be, as infectious disease doctors can attest. When hospitals were shut down at the beginning of COVID in 2020, suddenly we didn't have a lot of work to do because all elective surgeries were canceled. So this comes up quite a lot. Then we'll have to briefly just touch on other abdominal processes that antibiotics get used for frequently, such as spontaneous bacterial peritonitis, pancreatitis, and also we'll talk briefly about infectious diarrhea, but not C. diff. And then we'll just mention antibiotic prevention for infections, because this comes up a lot in stewardship programs, giving recommendations for how to prevent infections, just routine perioperative stuff. So there's a bunch of useful guidelines. I've updated the references in the last slide to correspond here. Some of the guidelines are very old. Many of them have been updated though. So we'll go over those changes since 2022. Okay. So complicated intra-abdominal infections. This basically, the definition is that enteric contents, stool or succus from the intestines, goes into the peritoneal cavity, leading to an abscess or leading to inflammation of the lining, peritonitis. So there kind of has to be essentially a disruption or a hole in the GI tract somewhere. And the main treatment is really surgical. You kind of just have to drain that stuff out. And the heavy lifting is actually the surgical source control. And I always think that antibiotics are kind of an adjunct. Probably the most common is appendicitis, but diverticulitis or cholecystitis are common causes of abdominal infections. And if it's a complicated abdominal infection, it would mean like the gallbladder basically ended up with a hole in it, and infection from there led to infection in the peritoneal cavity itself. So you can have these small contained perforations, which are not as big a problem as severe or large perforations. And with appendicitis, occasionally we actually treat these medically. We'll touch on that. If there's a large abscess around there, it can be drained or with surgery. There's also a trend towards not operating on perforated diverticulitis. That's actually pretty standard. If there's an abscess around a perforation of diverticulitis, the surgery is much more complex and morbid if you do it right away than if you can manage without doing surgery and delay surgery for a few months. So we'll talk briefly about that. And then the same thing with even gallbladders. Now, let's say there's an elderly patient with many comorbidities that would make surgery challenging, and they're sick in the ICU, for example. A percutaneous drain can be put into the biliary system or gallbladder to drain the liver and to drain the infection out, and avoid a surgery that would be more dangerous. And then sometimes surgery is done early, and sometimes surgery is actually very delayed or never done if somebody's nearly terminal. But the point is that there is a move away towards aggressive early surgery and a bit more to medical management, so it makes our rule important. If a patient is very sick, if they're septic and they have diffuse peritonitis, meaning like their abdomen hurts everywhere you touch them all over, that's really an emergency, and those patients really need to go to the operating room. So high-risk infection are patients that are more complex or severe, and these we treat as severe infection rather than mild infection when we pick antibiotics. These are old, the old guidelines have not been updated from the Infectious Disease Society of America. So basically, these standards are the same. The way I think of it is elderly patients, I would say 70-ish or older, low albumin, very poor nutritional status, or patients with malignancy, or patients in the ICU, in shock in the ICU. These patients are the ones we tend to use a broader antimicrobial regimen. This first delay in initial intervention for 24 hours, probably less specific for needing broader antibiotics, but these are the published criteria in the guidelines. So when somebody enters, typically these people are going to be in the hospital and they have complicated intra-abdominal infections. There's a hole in the appendix or severe diverticulitis. We tend to use a beta-lactam plus metronidazole. For our program, for many years, we just used cefazolin plus metronidazole. It's only been the last 4 or 5 years that our E. coli susceptibility fell below 90% for cefazolin. So we're now favoring to use ceftriaxone plus metronidazole. Normally the patients are NPO, which is why the metronidazole is initially IV. We try to get that to oral as soon as possible. These more severe ICU patients are the ones with complicated factors we looked on the last slide. Then we use a broader regimen that covers primarily more resistant gram-negative rods. And so that regimen would either be piperacillin tazobactam or cefepime and metronidazole. I prefer piperacillin tazobactam here. It's just cleaner. It's 1 drug instead of 2. It also has enterococcus coverage, which is not mandatory in all these patients, but it does provide a somewhat better spectrum, in my opinion, than the other drug as well. More challenging to treat are these healthcare-associated infections. The common example would be somebody has an abdominal surgery or Whipple procedure or something, and then a week later, the intestine that was sewn together falls apart and all the stool just starts spilling into the abdomen. Or this is a post-surgical infection, maybe an outpatient that comes back with an infection in the abdomen a week later. Those ones we also use a broader regimen of Zosyn or cefepime and Flagyl because they do tend to have gram-negative rods like Pseudomonas or Enterobacter, things like this. MRSA, even in healthcare-associated infections, is super rare. Literally, I've seen it once or twice in 9 or 10 years. So we just give MRSA coverage if something grows in those cultures, but we don't give vancomycin or linezolid empirically for those. My expert opinion would be if you know a patient has extended spectrum beta-lactamase, very resistant gram-negative rods in the GI tract, or has had urine with that organism recently, that means their GI tract has those bacteria in there. So if I know that from prior cultures in the last 1 to 2 years, I would use meropenem instead. It just is empirically makes sense, but this is not formally commented on in the guidelines. We should briefly just talk about metronidazole dosing. This has gone through some changes over the last 5 to 6 years. Many changes like these are prompted by antibiotic shortages, which we've had tons of in my career, and it seems like every year there's 2 or 3 different ones. So the nice thing about metronidazole is the half-life is very long. It's 8 hours. That's the same half-life as ceftriaxone. Now, as you know, we typically give ceftriaxone once a day. So there's really not a pharmacokinetic reason that we would give metronidazole 3 times a day when it has the same half-life to drugs we typically give once a day. The other thing is that it's concentration-dependent killing. So the area under the curve of the drug or the drug exposure predicts how well it works, not the amount of time the drug is above the minimum inhibitory concentration of bacteria. That basically means that dosing it once a day or 3 times a day, as long as you give the same total dose, should result in the same activity. So some institutions routinely just give this every 24 hours when using IV therapy. So for example, a gram or 1,500 milligrams, or in children, 30 per kilo per day. What most of us are doing now is just defaulting the dose to every 12 hours. The reason is because there's several studies, I've linked one of them here, that show that the outcome with 1,000, so 500, either altogether or 500 twice a day, has similar clinical outcomes to 1,500 milligrams in adults. And the limitation to giving every 24-hour oral dosing, like 1,000 once a day, is this does tend to be pretty nausea-inducing. A lot of patients have nausea with oral metronidazole, and especially at the higher dose. So every 12-hour dosing orally seems to be well tolerated, and it reduces the amount of drug used by 50%, basically, or by, I guess, a third. All right, so some just general basic points on abdominal infections. Patients that are not septic, that do not have hemodynamic instability, that have an intra-abdominal infection, blood cultures really aren't required. You do not need to do blood cultures on like a routine appendicitis patient or a diverticulitis patient who's admitted to the floor. It's very uncommon for bacteremia to be present. In the past, the guidelines from the Infectious Disease Society of America said if you have a perforated diverticulitis or appendicitis, you don't need to send cultures of the intra-abdominal contents when you drain them. The newer recommendations are to go ahead and send initial cultures. We are going to talk about this in a minute, but we don't recommend sending cultures on an appendix. So an appendix that's not ruptured, that the surgeons remove, they should not be culturing that appendix. It's going to have stool inside the lumen. That's why it's infected. We don't need to know what's in there. But if somebody has an intra-abdominal abscess, it is now recommended to get cultures from those. We'll also very clearly recommend not using ampicillin sulbactam because E. coli susceptibility is in the 80% range. And you'd like a drug to at least have 90% coverage for the most common bacteria you're going to find in these infections. We also recommend not using clindamycin, aminoglycosides, or cefoxitin or cefotetan. They just do not have adequate activity for the bacteria that are almost always there. I also just briefly mentioned enterococcus treatment. So for mild to moderate infections, these are basically people admitted to a ward but not an ICU. Ceftriaxone and metronidazole does not cover enterococcus, and that's totally fine. The guidelines favor treating for severe infections with a regimen that treats enterococcus. Cefepime and metronidazole really doesn't, and piperacillin and tazobactam does. So it's part of the reason I favor that for severe infections. If the patient's severely ill and enterococcus is grown in the cultures, if the patient's severely ill or it's a healthcare associated infection, it's recommended to treat that. If you had a very mild, tiny appendix abscess that was cultured and grew enterococcus and the patient's completely fine without treatment for it, you would not need to, chase that. But otherwise, we typically treat enterococcus, even though it's a very wimpy, non-virulent organism. There are not too many people that get ill from enterococcus as a general principle. And then this one's important probably because this seems to get overused a lot. It's the guidelines are clear that empiric antifungal therapy is not recommended for intra-abdominal infections. If Candida grows in cultures, then it should be treated. Most Candida is susceptible to fluconazole. Some species are not. So if it grows, we typically treat it, but we don't treat it if it empirically. And then if a patient is well enough or stable enough to then be treated non-operatively, so like say you drain with a percutaneous drain an abscess, then the regimen of antibiotics used ought to not be an antibiotic for a very severely ill patient, generally speaking, because by not operating and using a percutaneous drain, we're generally saying that the infection is mild enough to not require the more aggressive treatment. So typically this would be like ceftriaxone, metronidazole, and then we try to get them onto oral antibiotics to go home after some number of days if they still need antibiotics at all. They may not need antibiotics by that point, but if they do, we try to get them on an oral regimen. And as an aside, I'll just mention that we do often use amoxicillin clavulanate orally to go home even though we do not recommend using ampicillin sulbactam in the hospital. And the reason for that is that sulbactam and clavulanate are not the same beta-lactamase inhibitor. So amoxicillin clavulanate is actually much more active against E. coli than ampicillin sulbactam. And in most of our hospitals, 90 to 95% of E. coli is susceptible to amoxicillin clavulanate if you specifically look at that drug. So here is a trial from 2020 in New England Journal. This is called the CODA Collaborative. So I just wanted to mention the actual data on treating appendicitis with or without surgery. So this was a randomized, but not blinded, it's hard to blind surgery, study of 1,552 adults. And they could not have an abscess or free air, peritonitis, shock, or an anticipation that they needed an actual bowel resection. This is basically uncomplicated appendicitis. And they randomized patients to 10 days of antibiotics, and the surgeons could choose the antibiotic, or to immediate appendectomy. Most of the antibiotics were metronidazole plus Cipro or ceftonir. The antibiotics group showed a non-inferior result at 30 days of follow-up. So 30 days later, both groups seemed to be doing okay. It was a slightly shorter, and the hospitalization, I think, was longer than with surgery. But by 90 days, 29% of the group that was in antibiotics initially had received an appendectomy. So it reduced surgery, but still a third of those people ended up getting their appendix out anyway. And the thing was that the complication rate in the antibiotic group, basically relapse or some complication, was over 2 times what it was in the other group. So 8% in the antibiotic group, 3.5% in the surgery group. And this was basically entirely driven by the presence of an appendicolith, which is a really hard, calcified, it looks like a stone on the CAT scan. And if there was an appendicolith, a big hard stone in the appendix on the imaging, 20% of those people treated with antibiotics had a complication, whereas 3.6% without an appendicolith didn't. So uncomplicated appendicitis, but with an appendicolith, maybe better off just getting surgery, whereas without it, medical therapy could be a consideration. But the other thing, at least for Alaska, I think is important is that all these people chosen for antibiotic treatment had to be near a hospital, readily available to have high-level surgical evaluation. So if you're living in Boston or New York City, it may be one thing. But if you're living in Chivak or Akiachak, it might not be great to get antibiotics for appendicitis and still have a 29% risk of needing your appendix out in the next 90 days when you're in the village in winter and can't get to a hospital quickly. So now we'll just briefly talk about biliary infections. Those are caused by upper GI flora, which makes sense because the biliary tract drains into the second part of the duodenum. So it's really upper GI tract. And most of the time, anaerobes are not present. However, if a patient had a biliary enteric anastomosis, this is basically like if they had a gastric bypass procedure, a Whipple procedure, then lower GI flora can get up in there. But in otherwise healthy people, it's usually just upper GI flora. And so you can actually use ceftriaxone alone for stable patients, like somebody admitted to the hospital wards that needs a cholecystectomy. For severe infection, it would be similar. However, we do use broader regimens, piptazo, cefepime, flagyl, or meropenem. Because if somebody's in shock and in the ICU, there's still a small chance there could be Clostridium or something bad in there, and we want to just cover everything. Once the patient's getting better, what do we do, or how do we adjust the antibiotics when we have more culture data? So low-risk patients, again, stable patients, ward-type inpatients who get source control, surgery, or a drain and are improving, you really don't need to change the antibiotics. So although now we're saying to do cultures, let's say some Enterobacter grows in the cultures, but the patient's better and they're on a regimen that doesn't treat that. The antibiotics don't need to be broadened if they're doing fine. If they're not getting better, then we definitely want to cover what's recovered in culture. But because stool is full of, stool has 10 to the 10th bacteria live in our GI tract. 90% of the bacteria in our bodies are poop. And so there's always a ton of bacteria in these cultures. You don't have to chase every single one of them if the patient's better. If the patient's not getting better, we like to try to cover what we find. And that question comes up a lot. I get called a lot. Just a patient on a surgical service, something came back in the cultures, we're not covering it, the patient's better. And I was like, I just say, just proceed as if we don't know that. Okay, how long do we treat? Well, here's what the guidelines say. I can tell you that we or most people treat way more than this, but this is what the guidelines say and what the evidence base is. So we should try to follow the evidence base. If somebody has an acute stomach perforation, say a big ulcer blows a hole in the stomach, or they get a knife in the stomach, and they come in the hospital within 24 hours, then they just need an antibiotic. They just need antibiotics for 24 hours and then stop. There's a mention that if they are on acid suppression or have cancer, to give a longer regimen. This is what's in the guidelines. And that's actually, so I should clarify, the stomach and duodenal perforation, this is typically going to be ulcer disease. If it's repaired within 24 hours, you give 24 hours and stop, or a longer course if they're already on a PPI. If you have a knife in the stomach, penetrating or blunt trauma, or you're in a car wreck, or something happens in surgery accidentally and you poke a hole in the intestines and you repair it within 12 hours, then the recommendation is to just give 24 hours of antibiotics essentially for prophylaxis and stop. Sometimes these patients end up on very long courses and they really don't need that based on the guidelines. Appendicitis that's not perforated, we also just give antibiotics around the time of surgery and essentially stop. Cholecystitis, there's substantial data on this. If you just take the gallbladder out, you don't need much at all. And then if you put a biliary drain in place but you don't do surgery, then the recommendation is to treat for less than or equal to 7 days. Perforated cholecystitis, typically the recommendation is short course 4 or 5 days, similar to the other infections. So I'm going to show you the study. So complicated intra-abdominal infection, there's a hole in the intestine, stool gets in the abdominal cavity, there's an abscess, it's drained out, source control is obtained. The recommendation is to give 4 days of antibiotics. And so I'm going to mention that. So here's another study on cholecystitis, grade 2 acute cholecystitis. What they defined, these people are pretty sick. So white count over 18, fullness in the right upper quadrant, 3 days of symptoms, gangrenous gallbladder. This is pretty common actually, but they were sick patients. And they studied whether patients received less than or equal to 4 days or more than 4 days of therapy. And they found that as long as they had the appropriate source control procedure, typically surgery, that 4 days was just as good as more than 4 days of therapy. The other trial that's frequently quoted is the Stop It trial. This was 2015 New England Journal. I like this trial because it's easy to remember the name. And I'm not good at remembering study names, but this one's pretty easy. 500 patients with complicated intra-abdominal infections, and this was a randomized test. They randomized them to 4 days and then just stop, or to go up to 10 days of antibiotics, or stop when there was clinical resolution, which basically meant the white blood cell count was normal, there was no fever, and the patients were eating. The GI tract was functioning. So either you stop at 4 days with a white count still up and still not yet eating, or you go to 10 days. And what they found was that the antibiotics were typically 8 days in the other group, 4 days in the intervention group. But 21% of both groups, they had the same rate of recurrence. So still 1 in 5 patients down the road was going to have a relapse of some fluid collection in the abdomen that would cause symptoms and needed to be redrained. The difference was that in the group that received 4 days of antibiotics, that relapse happened right around day 10, so about 1 week after stopping the antibiotics. And the group that got 8 days of antibiotics had a relapse around day 20. So giving more antibiotics basically delayed the identification of a recurrence, but the rate or the likelihood of recurrence made no difference. So all that it appears we're doing by giving more than 4 days of antibiotics is pushing out the time that we're going to identify a problem pops up. So we try to give 4 days once there's been surgical source control or drainage source control. It's hard to achieve that, but that's what the data says. Now for diverticulitis, this is interesting. This actually gets treated in clinic quite a bit. Somebody has acute left lower quadrant abdominal pain. Perhaps they are known to have diverticulosis from prior imaging. Do we even need to give antibiotics? So there's a guideline on this from the gastroenterologist. And if there's not a perforation or sepsis, it's really unclear. If there's a hole in the intestines and there's an abscess in the intestines, they need antibiotics that we've been talking about. But the AGA, the American Gastroenterology Association, the guidelines say selective use is appropriate. And I'm going to tell you what they did. So several studies are pretty clear that show that diverticulitis gets better and doesn't have a difference in resolution, but there's a possible reduced recurrence with antibiotics, not entirely clear. So the guidelines actually say if somebody's quote unquote frail, that's a word they use, they have comorbidities and or immune compromise, refractory symptoms that are not getting better, or they have elevated labs, specifically a CRP over 140 milligrams per liter or a white count over 15, you should give antibiotics. But not all mild cases of outpatient diverticulitis may benefit from antibiotics. There's also no role for probiotics to decrease recurrences. Apparently, this is a thing that I was not aware of, but it's been specifically studied, and the guidelines say don't give probiotics to try to prevent diverticulitis recurrences. So what if you have a more severe diverticulitis that perforates and there's an abscess, collection of pus around the sigmoid usually? If the patient's septic and has pain everywhere, they need surgery. So those are the bad ones. But many of these are localized. So they're small, usually 4 to 6 centimeters or smaller. Those ones are frequently amenable to medical therapy. You give antibiotics, and then you can delay surgery and not need to do a much more complicated surgery immediately. There's a higher risk of basically needing a colostomy if you do surgery right away than if you delay it. However, the bigger ones, more than a few centimeters, I kind of like to say a golf ball, or anything a golf ball size. Maybe you can treat medically. I don't like to treat something much bigger than that without draining it. The larger ones, if you can drain it with radiologists can put a drain in, can culture the contents and then give antibiotics. If they get better, that's great. But if somebody fails to improve with medical or with radiology drainage after 3 days of treatment, then typically they're just going to need surgery. However, if you successfully can delay it and patients get better, then the surgery can be delayed. However, many of these patients do just go on to a scheduled sigmoid resection because there's a high recurrence rate if surgery is never done and 6 months or a year later, a patient comes back again with diverticulitis or complicated diverticulitis. Okay, so let's talk briefly about spontaneous bacterial peritonitis, which we see in patients with ascites, and it's defined off of the cell counts of the fluid. So this is in a patient with cirrhosis, specifically. Patients with ascites and heart failure don't get SBP nearly as often. So this is typically cirrhotic patients that are known to have ascites, and then they have signs or symptoms of infection. So pain, fever, maybe they're confused, and they look ill, or they have leukocytosis and they look sick. And if there's more than 250 neutrophils in the fluid, that is basically the definition of spontaneous bacterial peritonitis. I literally got a call about this morning, and that's why I put this bullet point in here, that the ascites guidelines from the AASLD, I think it's the study of liver disease, although that might be the AGA guidelines. They're very clear that if an outpatient's undergoing a paracentesis, just because they're tense and tight and they want the fluid out, so a therapeutic removal of fluid, But if they don't have signs or symptoms of infection, no fever, they're feeling okay, they have maybe they're a little bit uncomfortable because of the tension of the fluid, but they don't have peritonitis when you push on their belly, cultures don't need to be sent. They do recommend sending the cell counts just for monitoring, but cultures aren't recommended to be sent because frequently coagulase negative staphylococcus or streptococcus. I got called about a gram stain that said there was yeast, but nothing was growing. Sometimes those patients end up getting antibiotics for cultures that are contaminant and not real. So they don't recommend culturing unless you have a suspicion for infection. If the criteria are positive, the ascites, then we want to send cultures. If it hasn't already been done, they can be tapped again, and we treat them based on the white count. Most of the time, the cultures don't grow anything. So the old literature said ceftriaxone given twice a day for 5 days was preferable. The reality is, as long as they get 2 grams, whether it's 2 grams every 24 hours or 1 every 12, probably makes no difference, and the duration is recommended for 5 days. Cefotaxime is not even available anymore, so I'm not sure why I left that in there, but it's old stuff people talk about. And there's good data that 2 grams is better than 1 gram. The other thing is that if somebody is admitted to the hospital with GI bleeding, this is typically, it could be upper or lower. Many of these patients are upper GI bleeding, like varices, coughing up, vomiting up blood, and sick. Then that is a risk factor for spontaneous bacterial peritonitis, and they recommend giving antibiotic prophylaxis. If there's concern that they already have infection because the abdomen's tender or there's fever, then the ascites should be tapped. If there's no concern for that, sometimes a tap is not done, but ceftriaxone, just 1 gram in that case is adequate, can be given until the bleeding stops and the patient's off vasopressors, or up to 7 days in the old literature. Now, if a patient has an infection and we diagnose them with an infection, should they stay on antibiotics longer? And the best data is that if the protein level in the ascites is less than 1, that they're at very high risk of another episode. Most of these patients do have very low protein in the ascites. And so if there's a first episode of SBP, many patients would benefit from prophylaxis. The evidence is not great, but the guidelines endorse either Bactrim or ciprofloxacin. The oldest data was actually from one of the quinolones that's not available anymore. And so it's just been extrapolated to ciprofloxacin daily, just a daily dose. Bactrim, I try to use Bactrim when I can. Some of these patients have renal failure or have hyperkalemia, which prevents using Bactrim. Thrombocytopenia would be a mild concern for using Bactrim, I suppose, in a cirrhotic. Many cirrhotics are mildly pancytopenic, but most of them tolerate daily double-strength Bactrim okay. I worry more about the electrolytes. Okay, so we should now talk about pancreatitis. Not that anybody in Alaska ever drinks alcohol, but this is seen occasionally in Alaska, typically in people that drink alcohol or have a bad stone, obstructing biliary stone. And these patients are very, very sick. They look septic, they have high white blood cell counts, they're febrile, high heart rates, and right away, you can't tell for sure if they're septic or not. You can tell if they have pancreatitis because the lipase will be high, but you don't know if they have, septic or not. So they need blood cultures, they need empiric antibiotics, because if somebody's septic, you need to treat them until you figure it out. So if somebody is not in shock, they just have fever, some tachycardia, you can treat with pancreatitis as fluids, et cetera. But if it's ICU, they're in shock, they're unstable, need to get antibiotics, need to get blood cultures. And then if the blood cultures don't grow and all they have is pancreatitis, then the antibiotics really ought to be stopped after 24 to 36 hours. There still seems to be some disagreement, misunderstanding, fear, I'm not sure, that when CT imaging shows necrotic or dying pancreas, necrotic pancreatitis, that antibiotics should be given. And this is from way back in the early 80s. There were old studies that actually were to give antibiotics for 4 weeks to prevent infection. So if there was necrotic pancreatitis, like a third of the pancreas, they would give a month of ertapenem to try to prevent infection, and it didn't work because there was no decrease in infection or the need for surgery. But when the people did get infected, they were infected with highly resistant organisms, VRE or yeast or other junk. So the antibiotics really didn't achieve what was hoped and may have made the situation worse. So that's if there's necrotic pancreatitis, you shouldn't empirically give antibiotics. But necrotic pancreatitis definitely can get infected. No question about that. It happens a lot. That's why they studied giving antibiotics 40 years ago for it. So if somebody has necrotic pancreas and is not getting better after a week to 10 days of management, then you got to worry that there could be infection in there. So then the question is, how do you know if there is infection in the necrotic pancreas or not? And you can't know just by waving your hands over the patient or doing a rain dance or looking at the CAT scan. The only way to know is with cultures. And the guidelines are very clear. The only way to know if there's infection is to do cultures. So I think most infectious disease doctors prefer that a fine needle aspiration is used to remove some fluid from the necrotic pancreas before treating, so that we can figure out what's going on and actually know the diagnosis and treat it properly. So from a stewardship standpoint, I don't think there's any question that that would be the preferred approach. Interestingly, the American Cardiology, or the American College of Gastroenterology, they say they don't really think an FNA is a great idea. So they actually argue against it, and they say just give antibiotics, because their argument is even if the cultures are negative, if a patient isn't improving after 7 to 10 days and has infected necrotic pancreas, they are going to recommend giving antibiotics anyway. But they admit there's really no data for this recommendation. And they also admit that the only way to actually diagnose whether a pancreas is infected or not is with cultures. So I think most infectious disease doctors say if you have necrotic pancreas and the cultures are negative, it's not infected, as long as those cultures are done before a bunch of antibiotics are given. So so I think probably the summary here is that there's some conflict and there's some disagreement about how to approach this issue. Once you start, part of the problem is once you start antibiotics for necrotic pancreatitis, then you have to give them for a long time, typically like a month. It takes that long for the necrosis to sort of organize and to develop a thick rind, like an orange peel, around the area of infected necrosis. And about 3/4 of patients really can avoid a big surgery or drainage if you give a long course of antibiotics. At least in one series said that. If you do need to drain the infection later, it is easier for them to drain it either directly to the stomach, or if they have to, through a percutaneous tube. Once the organization is finalized and there's like a big pocket with a rind around it, because if the fluid's all unorganized and just leaking everywhere, it's very hard to drain it in any contained way. Guidelines recommend cephalosporins, quinolones, or carbapenems or metronidazole rather than penicillin. So the only thing they really don't recommend is, for example, piperacillin tazobactam, and they do prefer cefepime flagyl, or quinolone and flagyl, or carbapenem if they're specifically treating pancreatitis. So now I just want to talk briefly about infectious diarrhea. So sometimes we do admit people to the hospital for this. So let's just briefly touch on terminology here. So if you have fever and bloody stool, bloody diarrhea, that's dysentery, old biblical term. Community-acquired causes of this, there's quite a lot. Salmonella, Campylobacter, Shigella. I saw a patient I thought might have salmonella today. Rarely C. diff can cause dysentery. And then Shiga toxin, E. coli. How do we diagnose this? Cultures are typically what's been done. Many hospitals are using PCR, or nucleic acid amplification tests, NATs, now. There's also enzyme assays for Shiga toxin that are available. Most of the time, we would like to know what the diagnosis is before we slap people on antibiotics. This does not seem to happen often, but we try really hard to do that. Treatment is recommended if a patient is less than 3 months, if they're severely ill, or if they're immune compromised. I believe the main argument here is, what does severely ill mean? Emergency doctors or doctors in the hospital may believe that anytime somebody's admitted to the hospital that they're severely ill and therefore they need antibiotics right away. I would sort of argue they're severely ill if they're unstable, hemodynamics are concerned, they're in the ICU, et cetera. Somebody's admitted to the hospital with bloody diarrhea, I'd actually like to make a diagnosis before just slapping them on antibiotics for reasons that I'll mention in a minute. Also, immune compromised patients, let's say somebody with a heart transplant that has bloody diarrhea, that would be quite concerning. Outpatients could be treated with azithromycin, and you could actually do that for an inpatient that was taking orals if you wanted. Ceftriaxone is an option if an inpatient. For those hospitals that are using molecular diagnostics, these are like stool biofire tests or those stool gnats. Many of these will come back and say that, E. coli or Salmonella or Campylobacter's identified in the stool PCR. It's really important to send a stool culture before starting the antibiotics. Many places are not doing this, but public health authorities would like this for monitoring of Campylobacter outbreaks or Salmonella outbreaks, because they can do typing and they can do susceptibilities. So please send a stool before starting the antibiotics if the PCR is positive. Guidelines for treating infected diarrhea also specifically say that fecal leukocytes, which I see ordered all the time and I have no idea what to do with that, I don't find that ever helpful. And the guidelines actually say fecal leukocytes or calprotectins not recommended for evaluation of bloody diarrhea, infectious diarrhea. Travelers, how about people that somebody just came back from Thailand or Peru or something? So toxigenic E. coli, ETEC, that's sort of the classic traveler's diarrhea of E. coli, but Shigella, Salmonella, and Campylobacter as well also can happen. The preferred treatment is azithromycin. 1,000 once is actually just fine. Some people get nauseous with that and are better off taking 500 for 3 days. There's also a one-time dose of Cipro 750 or alternatively Cipro 500 for 3 days. These are regimens I recommend for travelers when they're out of the country. One of the reasons we try to avoid giving antibiotics for bloody stool up front is that in the chance the patient has cygatoxin E. coli, that's STEC, or what we used to call enterohemorrhagic E. coli. This is 0157H7 if you're taking a board exam. Those patients are thought to perhaps get worse and have a higher risk of renal failure and hemolytic uremic syndrome with antibiotics. So there's still a recommendation to avoid antibiotics in those patients. Data's mixed. How about somebody that recently was hospitalized or has been on clindamycin from their dentist? Then this is virtually always going to be C. diff, and that's an entirely different talk, which we'll get to in a month or two. So for this study, I did want to actually look at what are some of the real world impacts of using these stool PCR tests. Many hospitals in Alaska have them. Our hospitals in Anchorage actually don't have them right now, at least not locally. But I found this interesting. So those that had a PCR stent, a GI PCR stent, and this is thousands of patients that were looked at, a pathogen was found 29% of the time in patients that had a PCR stent, and only 4% of the time in patients that had a culture and a rotavirus or an adenovirus EIA stent. So much higher diagnosis. And what drove that was the viruses. That makes sense because viruses aren't going to grow on a culture. So of the 246 with a pathogen on the culture, only 38% were a virus on those virus tests, whereas 39% of the identified pathogens were viruses on the GI panel. And then bacteria was different. So in the culture, mostly what you found was bacteria, whereas on the stool PCR, bacteria were found 2/3 of the time. And the study claims that there was perhaps a benefit, mainly, even though it was a small benefit, that antibiotics within 14 days were given slightly less in the group with PCR rather than culture. Not much, but it was statistically significant. Not everything found on a stool PCR needs to be treated. Sometimes E. coli or other bacteria will show up there, and by the time that I'm called a week later, the patient has already spontaneously improved. And remember, as a general rule, it's very hard to improve upon asymptomaticity. By giving antibiotics that can cause diarrhea to somebody that recently had diarrhea and whose diarrhea is already better is counterintuitive. So we really try not to do that. All right, so now we'll just talk briefly about prophylaxis for colorectal surgeries. The regimens we recommend in the hospital sort of mimic the treatment guidelines for mild disease. We still do use cefazolin, at least have been using cefazolin and metronidazole, even though our E. coli is just slightly fell below 90%. I can't, if Shauna's on the call, she'll remind me if we've just changed this to ceftriaxone now, or in the process of changing to ceftriaxone. But this has been pretty effective historically. Ertapenem is an option if there's an anaphylactic cephalosporin allergy. What about if somebody's already on antibiotics and then going to the OR? This comes up a lot, that somebody's on Piptazo and then they go to the OR. So there are published redosing intervals. They're available in the guideline sets that are linked. Cefazolin is a little longer than other drugs. So like Piptazo is supposed to be redosed every 2 hours intraoperatively, whereas cefazolin is only 4 hours, and that's kind of nice. Ceftriaxone doesn't need to be redosed typically, certainly not for 12 hours at least. Cefazolin and metronidazole is easy, simple, safe, so a lot of places are still doing that. And we try to avoid using ertapenem. Ertapenem was pushed heavily 20 years ago by the drug company after they studied it for prophylaxis and got an FDA indication for that, and so they could market it for that. And the reason was it's just a single dose once, but we don't recommend postoperative doses anyway, and they're not mandatory, and it's very broad, has coverage. If somebody wants a 24-hour dose, ceftriaxone plus a gram of metronidazole can be given once and never has to be redosed. And so there are other 24-hour regimens that are less problematic than ertapenem. And I think that's where I'll stop today and take questions. So let me try to stop sharing here. Here's all the references. There's a whole lot for this one, but they'll be in the shared link. So let me stop here. Okay, there we go. See if I can pull the chat up.
There's nothing in the chat at the moment. If you have a question, feel free just to unmute and ask it, or put it in the chat, or whatnot. Looks like you got one now from Shauna.
Okay, sounds like I got it right, basically. So that's good. Especially, they're supposed to be my guidelines, but it's hard to keep up on. Dozens and dozens of guidelines we change all the time.
Did you address post-discharge antibiotic regimes?
Not really. Not really. The study of appendicitis, they used quinolone and metronidazole or ceftonir and metronidazole. Cephalexin and metronidazole is a reasonable option. Ampicillin or amoxicillin clavulanate, as I mentioned, is much better E. coli coverage than Ampsobactam. So we use a lot of amoxicillin clavulanate also. There's no evidence base to recommend one regimen over another. Actually, there's not really head-to-head trials of different regimens to see which works better. So nobody really knows. You'd think something so common people would know, but maybe AI will be able to tell us in a few months. Okay, well, it looks like we don't have any questions about this topic. If there are questions, they could be passed on later. And then I haven't looked at our calendar when our next one is.
Just pop the flyer in the
Yeah.
chat. April 2nd is Stewardship and Fever, Sepsis, Neutropenia.
Okay.
And April 16th is our last one on C. diff.
Okay.
2 more.
Great, thanks. We'll send out the recording to everyone, and I sent the slides earlier.
Sounds great.
Thanks, Dr.
Thanks,
Westley.
everybody.
See you in a few weeks.
Okay, see you later. Bye.
Bye.